Good morning, everyone. Happy middle of winter. I think we're almost exactly halfway through winter right now, so that's a good thing. I want to welcome everyone who is here this morning at Cambia Grove. Thank you for making the trip here to Seattle. And for those of you who are joining by a webinar, it's great to have you joining us as well. We have, I think, a really interesting agenda today to talk about. We're trying to set the stage for 2018 for HILN. It doesn't roll off very well, does it? I think it's usually HLIN sounds more right, but it's HILN. So it's good to have all of you here. My name is Bill Robertson. It's my privilege to serve as the President and CEO of MultiCare Health System. And as co-chair, it's nice to be co-chair again. I get to introduce my co-chair here in a second. No, but you told me you were just interim, so I have a permanent. So it's really good to have all of you here. So I'm going to set the stage today by giving a brief view at the objectives we have for today. Then I'm going to let everybody introduce themselves so we can get a sense of who's present. And then it's my privilege, and after that, I will get to introduce Sue to all of us, and then she's going to really take the agenda forward today. So starting with what's on our agenda today. The first thing we want to do is understand health systems transformation priorities for the year ahead. So we're in a transforming healthcare delivery system, financing system, societal system, whether we want to be or not. I mean, I think we just have to recognize that, and it can either transform in some way intentionally, or it's just going to transform unintentionally. I think we'll get better outcomes if we work on it intentionally. So that's the first of our objectives today. What are our priorities for this year? We want to discuss where we've been, where we are, and the challenges we face to continue in advancing to a healthier Washington. You know, we've talked a lot about value-based purchasing, and that's a vehicle for this, but the real end game is a healthier Washington. I mean, that's what we're trying to get to, is a healthier community, which has huge positive benefits in all kinds of ways that last for generations if we do this well. And then we need to agree to a direction for the network's 2018 action agenda. So that's what we're hoping to accomplish today. We have about 3 hours to do this in. And a lot of this work is going to be done by you. So that's the challenge. We're going to need to be actively get engaged in this as we go forward. So we have a microphone we're going to pass around so people can know who it is, who's speaking. So I'd ask you to do two things, or it's really three things. Tell who you are, how you're associated, you know, how you're here, so your role in life, and then how long you've been a participant in HILN. Some of us have been here longer than others. I've been here just about 9 months is my tenure. This is the first meeting for, I think, 4 people who are joining us, and then some of you have been here the whole journey. So I'm gonna, you have the mic, right? We're gonna start in the back, the lady in red, and we're gonna work our way around today.
Morning, I'm Diane Narasaki, Executive Director of Asian Counseling and Referral Service, or ACRS, and I've been here since the beginning.
Hi, and I'm Doug Conrad. I'm the Principal Investigator from University of Washington of the evaluation of the overall state innovation model.
Hi, I'm Dre Fresco from the Yakima Health District, and I've been here from the start.
Hi, I'm Michelle Needham. I'm the Chief Policy Officer for the Healthcare Authority, newly in that role since November. I've been on the project, however, from the other side with the legislature for a number of years.
Good morning. I'm Regina Delahunt. I'm the Public Health Director for Whatcom County, and I've been here from the start.
Good morning. I'm Jürgen Unutzer. I chair the Department of Psychiatry and Behavioral Sciences at the University of Washington. I've also been here from the beginning.
Hi, good morning. My name is Martin Mueller. I'm the Assistant Superintendent for Student Engagement and Support at the State Office of Superintendent of Public Instruction. This is my first HILN meeting, although in a prior life at the Department of Health as an Assistant Secretary there, I've been very familiar with the work of HILN in Healthier Washington.
Hi, I'm here on behalf of Diane Sosny at SEIU Healthcare 1199 Northwest, a union of 30,000 healthcare workers across Washington. My name is Sybil Hippolyte. I'm our healthcare policy specialist, and our organization has been here since the beginning.
I'm Michael Erickson. I'm the Chief Executive Officer for Neighbor Care Health, and I've been in Seattle for 2 years, and so I've only been here just shy of 2 years.
Hi, I'm Maura Little. I'm the executive director here at Cambia Grove. Our organization has been here from the start. I've been here for just a couple months.
Hi, I'm Molly Voris. I'm the policy director at the Washington Health Benefit Exchange. The exchange has been involved with this group since the beginning.
Good morning. I'm Phil Colmenares. I'm the Chief Medical Officer at Primera, and this is my first meeting.
Well, thank you very much. Good morning. I am Tammy Moore. I'm with Summit Pacific Medical Center. We have a great relationship with the Healthcare Authority. I've been here for about 26 minutes, so this is my first meeting. So please be gentle.
Good morning. I'm Joe, CEO for Kitsap Mental Health. I've been here since we started.
Hi, everyone. Nancy Gento with the Washington Health Alliance, and we too have been here from the beginning.
Hi, I'm Doug Bose. I'm the CEO of United Healthcare here in Washington, and I guess I've been here from the beginning too.
Hi, I'm Janet Barron. I'm the Director of Northwest Health Law Advocates, also here from the start.
Good morning. I'm Jana Wilson with King County. I'm here today for Caroline Whalen, and King County has been involved since the beginning.
Good morning, I'm Aaron Spark, Government Affairs Officer for the Seattle Indian Health Board. Also, this is going to be long. I'm the Executive Committee member for the American Indian Health Commission of Washington State and also a delegate for the Indian Policy Advisory Council.
Good morning, I'm Sue Birch. I've been watching you guys since 2010. I'm the new director of the Healthcare Authority, and I've been in the state now 40 some days, I think.
John Weisman, Washington State Secretary of Health, been here since the beginning, and I'm thrilled to have Sue on board and for you to truly have a good co-chair.
Good morning. This is I'm Peter Adler, President of Molina Healthcare, and Molina's been a founding member of Hill since the very beginning.
Good morning. I'm Hugh Straley. I'm and fortunate enough to be the chair of the Dr. Robert Bree Collaborative, whose humble goal has been to transform healthcare since its origin in 2011, and I've been here since the beginning.
Hi, I'm Ann Christian. I'm the CEO of the Washington Council for Behavioral Health, and I've been here since the beginning as well.
Good morning, Winfried Danke. I'm the Executive Director of Choice Regional Health Network and also lead the Cascade Pacific Action Alliance, one of 9 accountable communities of health in the state of Washington.
Good morning, I'm Laura Kate Zeichkin. I'm with the Healthcare Authority and I am the Healthier Washington Coordinator.
Good morning, I'm Rachel Quinn. I'm with the Healthcare Authority. I work on value-based purchasing and payment strategies.
Good morning, I'm Kristen Bies with the Healthcare Authority, and I work on Rachel's team on our value-based purchasing initiatives.
Good morning, I'm Kennedy Swallow. I'm the Health Transformation Communications Manager with HCA.
Hi, I'm Julie Anderson, and I am the Assistant Director here at the Cambia Grove.
Hi, Ginny Weir, Director of the Bree Collaborative.
So it's a great swath of expertise and experience and perspective from across all kinds of sectors inside the state of Washington. And we have a great team that we're working with at the Healthcare Authority. I do want a special call out to the Cambia Grove for making this space available. It's a great collaboration space. I get to be involved here on other things as we're looking at innovations and things like that. And so thank you to Cambia Grove for being a part and also making this space available to us today. So now it is my distinct privilege to introduce someone to you who actually I've just been meeting on the phone until this morning for the last several weeks. But we're really pleased that Sue Birch has emigrated from Colorado to the Pacific Northwest. I think she had her start on the East Coast, so she's slowly making her way to God's country. That's how my grandparents saw this, because that's where they were from, is God's country out here. As I've been getting acquainted with Sue, I've come to realize that she has this amazing depth of experience in lots of different things. So embedded in a community where you're making direct contact with the people you serve through organizations she's led there. And then at some point she was called up to be the partner with the governor of the great state of Colorado, and she has some really interesting stories about how they started making transformation happen through the Medicaid program in Colorado. Some really interesting agenda there. And now she's come here to bring this wealth of experience and her curiosity, because one thing I've watched is she's curious. And, you know, I have this motto myself: more curious than certain. And I think that's an attribute that I've seen at play with Sue. So it's my privilege this morning to introduce the director of the Healthcare Authority and my permanent co-chair of the HLN, Sue Birch.
Thank you. Wow, that's a pretty great way to start Friday. I'm gonna just scoot this over. This reminds me so much of the Capitol Factory in Austin, if any of you have been there. But I love that it's dedicated for health innovations. So truly, it is an honor to be standing here with you guys as part of your team. In Colorado, we were always neck and neck with you all, racing for this. How do we be transformation busters? How do we get the most out of the last administration? And how do we, you know, continue to blaze this trail forward? So I was just so excited when this opportunity came up, and my kids, who are still back in Denver and kind of one in Idaho, were a little bit like, Mom, what are you doing? It's gray and raining and you got plenty going on in Colorado. And I said, no, this is the team in the country that's going to be doing the breakthrough work in the nation. So you have been, and it's great to be here and great to be part of this and co-creating. You guys are so directionally spot on. So I want to just share with you some reasons why I think that is, and then I want to kind of talk a little bit more about where I think we need to go. And I apologize because I don't have all the factoids yet, so I needed some cheat notes, because truly it's not been that long that I've been here. We have all accomplished a lot in this short time frame, and I do want just to give you a snapshot, because there's one thing you will come to know about me. Even though I'm a nurse, the MBA brain in me really likes numbers too. So I'll be spending a lot more time as we get more resources available to us to be syncing up some of our data and evaluation points. But here are just some things that are important to celebrate and to refresh on. We have clearly in this state been moving the market and seen as a market leader in paying for value. This is demonstrated by the 30% of state financed payments being value-based. We've been increasing the enrollment in VBP for public employees by 42% since the last enrollment, and that's up 17,000 enrollees in 2017, gone to 25,000 enrollees in the ACO model in 2018. We also implemented total joint replacement bundles through the Center of Excellence, which I know you guys know, but it's important for you to celebrate 114 active participants, saved members right shy of 100,000 in out-of-pocket costs. I mean, that's, I know that it's small, but it's a beginning and it will all add up over time. Also, you'll hear me say we aren't sophisticated enough in the US to accurately measure savings, and I'll be talking more about that in just a little bit. We also have really made the grade on integration and team-based care. Nearly 200,000 Medicaid beneficiaries are getting integrated physical and behavioral health services under the managed care in 2 regions of the state. By this time next year, half of the Medicaid beneficiaries will be in integrated service models. Those regions and providers have been performing better on most measures of quality than providers in regions. In Colorado, where we started this movement as well, in our non-transform practices, we found, for example, on maternal depression, early identification and screening and monitoring, we were below 20%. By the time we went in and did true practice transformation and got things to really stick, we jumped those results up to 70 to 80%. And those are the kind of factoids in the future that I hope to be bringing to you, because I think if we can start making a lot of this more tangible, where somebody goes, oh, I get it, a maternal depression screen, then I think we bring people really into the more into the conversation. The Practice Transformation Support Hub onboarded and assessed more than 300 provider practices. And again, one of the foundational things that I think both our states have really aspired to do is to get more standardization in primary care health homes. And so I think when we can say, you know, we've got 90% of our folks in PCMH type models, that's going to be really exciting. But 300 provider practices, and their focus is on that integrated team-based care. I hope in the very near future to also be bringing up a lot more efforts around new consumerism, and I think that will also drive a lot more of this whole person care and more of the work that we probably have a lot of opportunity with this current administration on what we can do with some of the supportive services, and I'll again visit on that as well later. Washington State is the first and only in the nation to certify patient decision aids, and I am telling you, we just couldn't believe you guys pulled this off. But HCA has certified 9 patient decision aids and is undergoing the largest review to date of 28 end-of-life care patient decision aids. NCQA recognized the use of those aids in health plan accreditation guidelines, and several of my NCQA friends and I have again been just absolutely astounded with your progress there. Another success, communities are supported in clinical community linkages. So the accountable communities of health, and I know we have some of our partners here, 54 million in incentives began, and an additional 180 million will be going out the door shortly. And that's going to really help building up the community capacity that is so needed. In this country, it's been great that we've all standardized or began the movement in standardizing in primary care realm. It's also fabulous that our behavioral health integration is beginning, and that bill passed out of the House unanimously. It's got to get through the Senate still. But the behavioral health folks that are coming to work within the Healthcare Authority, that movement of truly leaning in and starting to get behavioral health integrated and standardized is going to be no small feat for all of us. But these funds are going to help our ACHs move into that space of helping with that standardization. The state also soft launched some foundational community supports, and in the first months, there's 48 providers across 100 service locations representing most of the areas of the state, and there's 29 enrollees receiving supportive housing and supported employment services. Now, I guarantee you this is underrepresented because I have talked to many of your housing leaders that I've met nationally, and again, I don't think we have the sophistication yet to truly capture some of the linkages that you'll be hearing about. But that is great because you are in this country seen as one of the strongest housing groups. And then lastly, and not leastly, this whole movement about what you've thought about with your transformation waiver and the aging and disabled. You've got 560 enrollees in the long-term care services and support arena with supportive family caregivers, and we, for all of our sakes, that is going to be the area, long-term services and supports, where we all have to go very far and long into the future, because as we all know, that is where all the resources are really being consumed, and maybe not the wisest investments. So those are just some of the factoids that I asked from my team to pull together, because I'm hoping in our time in the future that we can really get a lot more of these success metrics available to each and every one of us, so that we can be braggarts in the state and help people understand what we're doing. Because I talk to a lot of folks that go, you transformation people, you guys that are working on Obamacare, we just don't get it. Now, I talk to a lot of others that kind of are starting to understand co-pays and health literacy, and your legislators here are really sophisticated. I have not had to continue to remind them the difference between Medicaid and Medicare, so I've been so pleased with the level of sophistication in this state. But I want to talk now a little bit about you all and the role you play and where I see things going. But I will tell you, I celebrate your successes thus far, and I look forward to helping you capture all the data points that will really show people all the work that's really underneath it all in this transformation process. So I think it's a little important important to know a little bit about me, just because I apologize in advance. Somebody said not too long ago, you know, so you probably should be medicated for some of your thinking. But as a nurse, I really have just been so blessed over my entire career to have some opportunities that have presented that have really framed my thinking. I started out kind of thinking I would do more traditional kind of community health, public health nursing, and spent very little time in hospital settings. Anybody that knows me knows one of my big aspirations in life is to spend no time in hospitals ever. And that's not that we don't need them. I just think the state of well-being and the state of being healthy is where it's all at. So I spent a little bit of time in urban settings. Having grown up on the East Coast, I fled all that density and whatnot and came out to the Wild West and just loved it. And as Bill shared, I just love everything about the West. I love the healthiness of how we all live. And I think that we in the West will really create more of this culture of health that our friends back East talk a lot about. But I truly believe with the opportunities we have with environment and economic and social issues, we can really raise up to that challenge. So I spent decades out in rural frontier Colorado, and because we were small enough, we were able to fly under the radar. And we also had a certain political insensitivity because when the state wouldn't help us, we reached right to the federal government. So Tom Scully and a few of folks that somehow I had the good fortune of getting cell numbers for would say, oh, she was the lady that was just crazed about rural healthcare. And so over that time, I also was awarded many very large multi-million-dollar gifts to experiment. And so innovation has always been key in my brain around creativity. Maybe because my dad was an architect and builder, I kind of can see things far out. People say to me, you're always 10 years ahead of everything. And I say that very humbly because it's never me, but it's a team of people. But it's really important that we stay in this innovation creativity mode. And that's not to say we don't have a lot on our plans right now, but we can't stop course correcting as we go through things. So when I had those opportunities with private philanthropy dollars and federal dollars, I experimented a lot. Things like aging well, getting some work done with the Arthritis Foundation on why fly fishing for the elderly was a cool thing. Getting Tai Chi, going in Maybell, Colorado, which is a town of 600 people, and the route or the Republican county commissioners were like, you're talking communism and that's that crazy stuff. But we're attending, and we had huge aging well activities. We also did things like bringing up hospice homes that were small scale homes that allowed people that were homeless or didn't have safe places to die to go and have a non-institutional feel. We brought up green homes in Colorado. So we created the new version of nursing homes that are built around hearths and kitchens. And I tell you this because we've got to envision a future of a different sort of amenity for a culture of health. We've got great institutions, and I love all my hospital partners and love all my traditional kind of skilled nursing. They're part of the continuum, but we have to imagine other amenities that will keep us healthy. I was so lucky that President Bush sent a team of 8 of us. Before Michael Moore went to Cuba, Bush allowed 8 of us to go to Cuba. And what we saw there was a transformed, I mean, just invert your jacket, turn the system inside out. And we saw the base of primary care all throughout the regions and so accessible. We saw the abuela clubs, the grandparent clubs, where the elderly were coming in and there were the horn section and they were doing that. And then they were playing dominoes over there and the kids were filtering in. And so the elderly could come to what we think of as our senior daycare centers. And then we saw extraordinary regional specialization being available. And then we saw gutted out hospitals, truly with no glass and no windows, but doing quite well. And what we went to validate was, yep, in the US, we spend $5,600 per person. And in Cuba, they were spending $500 per person and getting better value and better outcomes and better longevity. And it just reshaped my thinking. And that was back in 2004. I also was really fortunate with the fellowship that Robert Wood Johnson Foundation gave me to help become part of this team that works with all of you and all of us to really disrupt. And so we've been disrupting. And so my thinking has really been impacted as a nurse who thought, oh, we can advance and save lives in hospitals and traditional settings, to we got to get out of traditional over-medicalization in this country. We've got to bring up the social well-being side of things. So the other thing that happened, I'm just so lucky because somehow I landed in Steamboat Springs, Colorado, where if anybody wants to go skiing, just let me know, because I have my ski pass, which is available. Although we have great skiing here too. The folks that would come in for the Aspen Ideas Festival, or the folks that would fly in for some of the glitz of Colorado, would often get pretty disheartened with hanging out with the quadrillionaires, and they would want to spend more time with real folks. So they'd come over to Steamboat, and so spend a lot of time kind of hiking and walking with the likes of Alice Rivlin and Henry Aaron and some of the other kind of economists that really wanted to understand things like home visitation programs, and really wanted to understand that, well, the health people understood triple aim. Those guys really got it, but they really weren't talking to their social economist friends, Richard Reeves and Bell Sawhill and Ron Haskins, about poverty and what they call the success sequence. The success sequence in the social arena is just our version of triple aim. And when you get social and health circles colliding, you really can create some action. So I tell you this because our accountable communities of health have such extraordinary opportunity to do things like we did in Colorado 7 years ago, when somehow the anonymous donor of Mr. Buffett sent some scouts in to say, hey, we want to experiment quietly about teen pregnancy in your state. Will you help us do a complete landscape of transformation? And so what they did was they propelled us to really help with the uptake of LARCs, long-acting reversible contraception. And it's my education friends back there in Colorado that called me right before I left saying, oh my God, you guys helped us move the dial on our graduation rates. And how we did that was a complete transformation. So we had the private resources that came in to help us figure out the funding transformations, because we had to create better ways to fund things with our partners in public health. We also had to do complete provider and workforce restructuring. So we went through very significant lean business process redesign to help those clinics know how to work with the clients to get them LARCs if they chose it. We used new consumerism because we had to get the clients really going through what we said was our cowboy version of shared decision making or decision support aids. And lo and behold, the uptake was extraordinary. In 6 years, we saw the teen pregnancy rate in Colorado drop by 60%. We saw the abortion rate drop by 48%, somewhere between 40 and 50, because Guttemacher Institute keeps like moving the data forward. Or we get further into the outcomes of the project. And the high school graduation rates dropped up. So if we can do nothing other than reimagine our thinking in this state to work on 3 new fundamental pieces of the success sequence, which are forestall childbearing till 21, meaning have more intended and wanted pregnancies. Really, really critically important. Have more kids and adults with high school and GED rates, which seems so non-aspirational, but I'm telling you guys, we've been going backwards in this country. And then lastly, everybody with some sort of work ethic or purpose ethic. And I find this so ironic because in Colorado years ago, we had moved all the intellectual and developmental disability programs into our authority in Colorado. And 100% of our IDD kids and adults had work coaches, and they were either working or contributing, or they had purpose. So if we can unlock the power of the success sequence, those 3 things, and marry them to the triple aim, we will succeed in this state. It's no small secret that I'm definitely a public health nurse and love kind of more of this notion of we can't just be a traditional insurer anymore. we are just at that moment in time, just like when seatbelts and just like when antibiotics came up, and unfortunately we've gone the other way with antibiotics, but we've got to understand the power we have in coverage. And that will, as we, I know we'll careen past 95% covered lives, but we've got to make sure our plan designs are different. So we have to, in our value-based thinking, start maturing to think about how we use intergovernmental contracts. How do we use local tax base to leverage the dollars differently, to pull down federal match and then redistribute that back into the system, either on wherever the evidence shows that we need. But we're going to also, and Laura, how are we doing on time? 2 more minutes. We also have to think about, we've got some amazing BRIE collaboratives and centers for evidence-based, and where's my Washington, UW folks are back there. We've got some amazing stuff going on in, again, measuring the over-medicalization, but we got to get over and support our social friends. We've got to figure out how we bring up a better center for evidence-based social policy making. We've got to figure out, too, the role of public health. We're doing some very interesting thinking about what we need to do to be better positioned for emerging infectious diseases. I mean, we need to think about potentially avoidable social conditions in a different way, and we need to think about emerging infectious diseases. And those things are like imminent. I was listening to an NPR story this morning, or maybe it was last night, about kind of the stratification of the tax structure here in this state and what that's going to do with widening the chasm. We do know in this country that we have far more people not moving into middle class by middle age. And that's a real problem if we have all sorts of dependency early on in life and never get them to kind of stand alone, and then they're dependent again on their aging stuff, and we just do a lot more futile and unnecessary care. That's going to be a real tipping point in this country. So I will end by saying it is just such an honor and privilege to work with you and amongst you, and I see this as an opportunity for us to co-create and to build upon the incredible kind of work you've done. I tell my 3 kids all the time, take stock of what you've done in your life, and I think we have to keep looking back and know that we've had a lot of strength to build what we've accomplished thus far. Those are some of the metrics, but we also have to keep pushing ourselves to innovate and to be ready for the next challenges ahead. And we've definitely got to scramble on some of the infrastructure work around data and how we use the whole field of predictive and prescriptive data analytics. And I look to my commercial friends that have been doing this for some time and just say we intend to use some of that thinking as well as we move further and deeper into how we stabilize health and education in this country. Because without that, we lose that 3-legged stool. We lose the social sector. I would argue that we're losing the front on the environmental sector, and I would say that our economic center, those 3 legs of the stool for healthy communities, they're a little concerning to me right now in this day and age. So I would hope that we collectively think about how we use our health gravitas to really stabilize and create true communities of wellness. John encapsulated those words yesterday. So it's a pleasure to be with all of you, and I look forward to questions. Or Laura, what's next? Questions, easy ones, please. Yeah.
Oh.
Can you remind me who you are?
Oh, yes, Andre Fresco, the Executive Director of the Yakima Health District.
Oh, right.
One of the things that's often difficult when I'm asked about what are the inputs that we could make in public health to ensure people's improved health and longevity, it's exactly what you talk about. The reality is that if children could graduate from high school with a plan for college or work plan, if they could graduate without having the difficulty of a teen pregnancy, without an addiction, without a record, that life would improve in far greater capacity than the work actually that I do every day. One of the complexities, though, for me is that our current systems don't allow for some of the innovations that you're talking about, whether it's funding or jurisdictional responsibility. And so I was just hoping if you could provide some insight into how we in different sectors can work more collectively in ensuring some of these things that frankly are cross-sectoral. We have to work collectively, and it's not just the responsibility, as an example of education, to grow healthy kids. It's all of our responsibility. It sounds aspirational, but it's not always easy to put into structural work. So,
You know, I used to blame it on the feds, saying the feds won't let us do that. We can't do that. We can't braid and blend and mix and match. But, you know, I will point to some of my private counterparts. Jeff Bremer and I talk every now and then, and others that have been bringing up more of what I call the intersections. And I think we've got to look to our private partners. I also think we have such an extraordinary opportunity with things like social impact bonding and all of the very creative financing. I just was on the phone last night with a group that is doing some extraordinary backing of housing initiatives, kind of creating relationships with the nonprofit sector. Very interesting, kind of like how we all think about co-signing with our children as we help them get into very expensive housing. It feels like everything is expensive these days. And I say that because I tried to buy a home in Olympia. Pam McEwen's not here, but Pam and I were outbidding each other, and we were both outbid by somebody else who way overbid. And we were going, this is ridiculous. This is like small condos and $500,000. And yeah, anyways, my point is we have more opportunity than you think. So there's a gentleman, Keith Fontenot, who was at the controls of the federal budget, who was like, he can take us deep into the bowels of how we do braided and blended funding in more creative ways. I would also tell you that the venture philanthropy, I am shocked. It was one of the reasons I was very interested in coming here. In Colorado, we probably brought in $250 million in additional resources, private, to match government. And I said to the governor, sure, I'll come up and work with you. You guys are considered kind of the rebel alliance, the renegades. And I was like, sure, I'll come work with you guys, but you have to let us really run with private philanthropy because you need this public-private mix, which is kind of the beauty of what I see with some of the MCO partnership work and the ACHs that are evolving. So I think we're our own worst enemy. I think we haven't been smart enough to figure it out. If you look at people like Dr. David Olds with the Nurse Family Partnership, he has, like, I think now almost 4 decades of data showing his savings in criminal justice and housing and educational attainment on the home. Those CRT studies show that home visitation more than pays for itself. I think we just have to be smarter about figuring how do we rearrange the system to drop people into the evidence-based programs without them even fully understanding that, and then we make them work to get out. Right now, we make our Medicaid clients work to get into many of these programs. And I would also argue that because Medicaid has such enormous social burden issues, that we have a duty to rearrange those systems and work together differently. But places like yours are the perfect place to do more of that experimentation because it's small scale.
Good morning. Hi, Maura Little, Cambia Grove. Welcome to Washington. We're thrilled that you're here. Question about the data infrastructure that you were mentioning. Can you dive into what exactly you're thinking about there? Are there other states or other industries that are set up in a way that can measure and capture what a perfect world scenario looks like for you?
So this is going to be a short response. I think actually we're going to have to look to some of our commercial friends that are already ahead of us, and we're going to have to think about how they share some of their simplification. I will tell you I spend a lot more time with the innovators in the whole predictive prescriptive analytics arena. Right before I left Colorado, you should have seen me, I was jumping for joy when I found out that the whole population of folks that can't afford more than 30 to 60 days of cell service pretty much just need case management right from day one. You should just immediately, and if you don't even have if you can't even afford a cell phone, so it is, I just think we're going to have to look at some very unusual data sets that, and I know the rest of the world already is because I do know where I'm standing in tech country, but I think I don't have a clear vision yet. I will point to the social services folks, RDA, is it RDA? I think on our governmental side of this, we're going to have to look at how we bring up a health information utility for this state. I think we are right now tripping over so many fabulous initiatives that have been outsourced and that are out there, but we also see some fragmentation that is unnecessary. So I think we're going to have to get a lot of this data capture simplified, and then I am big into the whole data aggregation piece, and I know I'm butchering this. There's so much more to be thought about with moving in our data overhaul. We did have a recent leadership change, and so it gives us some opportunity within the authority to rethink some of the progression. And I don't fault anybody. We've been maturing kind of data feeds over the years. I know all of us have lived through the establishments of exchanges. Where's my Pam? Where did her Molly left? But we all have war wounds from kind of coverage. I think this whole arena of your core measure sets are phenomenal. How do we kind of keep refining this? How do we keep refining the data captures around VBP? I've lived through a very interesting APCD world in Colorado and look forward to more of those conversations here. So all of those things have to be looked at, streamlined, kind of re-hung. And quite frankly, I think we're going to have to look to our private sector too, to look at how does all of this, just like when we, and I didn't live through this because I'm not that old, but my friends who live through rural electric co-ops say to me, and my friends that brought up Medicare have often said, what you all are doing is like when we laid that basic infrastructure. And I think we are going to have to probably look at a federated kind of health information utility model for the future where everybody shares some of that burden, because it certainly can't be government alone. So stay tuned on that. I have some ideas, and I'm hoping we're all going to be working on that problem together as well. That was a tough question. Yeah.
Given what you bring to the state of Washington, hi, I'm Joe with Kitsap Mental Health. I was going to ask if you could reflect any lessons learned on Amendment 69 that you went through back in Colorado.
Biggest legislative defeat in Colorado history. It was
Exactly.
our universal health care initiative. What did we learn? Wow, could we do that at a different time with alcohol involved? No. I'll just say personally, I think this has got to be a national lift. I just think state by state is just going to be so extraordinarily problematic, especially right now where we can barely hold and or get more Medicare in, Medicare data sharing, Medicare involvement with our new federal partners. So I just will just tell you that I'm a little biased about let's make that a national lift. And because I worry state by state, it's a real problem. It's a really extraordinarily difficult lift. And I was more excited about focusing on all the transformation that was achievable and just kind of helped us bring more immediate returns just because of the obstacles from a national perspective.
Peter, you get the final question.
Sue, I love your inspiration and your experience and your passion around bringing the social determinants and social justice into the definition of health and healthy communities. I wonder if you could, from your experience and looking at the chart on the on the wall, the last bullet of sustained transformation, one of the challenges I think we face right now is in the state is we've become overly focused on the waiver and its milestones and what needs to be done this year and next year, and not continuing to look at the chapter after 5 years, which is now 3.5 years. So could you just share your thoughts and experience around the sustaining transformation and how we not get stuck in the bureaucracy of meeting the requirements of a waiver and instead stay stuck in the world of transformation that has a much longer runway?
Yeah, another nice, easy question. Thank you for that. So, I actually think the sustainability will come from all of the efficiencies that we gain and from all of squeezing the bloat and waste out of the system. And Nancy's shaking her head going, yeah. That 285 million was just an easy capture. When we start measuring the waste on the social side and the dysfunction, I think that's where we have the opportunity. But I'm going to pick on the MCOs a little bit too. I mean, part of why Colorado went to a regional care collaborative organization model was, our ACA, our RICOs weren't initially capable of being risk-bearing, but I would say that we've got to take the riskiness out of kind of the social sector of the US because it's crazy right now. So I do think we're going to have to look at all sectors and look at where do you take the bloat, where is it a value proposition. And I just think there's plenty of dysfunction all across the continuum that we will be able to repurpose some of that and be able to capture more success. So if we do nothing but standardize, if we just stop paying crappy everything, there'll be plenty of money to repurpose. But I think we can be more aspirational than that.
Thank you, Sue. I think we will have opportunity to chat more about this, particularly how we're keeping the long view, how we're making sure that wellness is part of the sustainability equation, and to really think about how we, as accelerators, as pioneers of health systems transformation, can really start to move the needle on wellness and well-being and a healthier Washington. So we, I figured that everyone would want to get to know Sue a little bit. So we are going to flex the agenda a little bit today and probably go for 20 or 25 minutes to just look back. Because after the break, we are going to look forward and start thinking about how we as individual organizations and also as a collective leadership network can develop an action agenda for the coming year and years that is focused on well-being. But first, I want to make sure that we are thinking about where we've been. The Health Innovation Leadership Network really first started as ambassadors of Healthier Washington, understanding how we could get a better education, how we could educate our boards, our organizations, our leaders, and also some of our constituents around the importance of health systems transformation and the components of better health, better care, and smarter spending. And then over the course of the next few years, we really thought about how do we take action? How can we accelerate the work, again, both as individual organizations and as a collective? And that manifested itself last year in an action agenda that really was about a commitment to value. We did put at least one of those action agendas on everybody's tables so you could refresh your memory. But it really started with, what does value mean to you? And it's a lot of the themes that Sue brought up when we were thinking about well-being, wellness, healthier Washington, healthier people, healthier populations, around equity, around access, affordability, consumer engagement, and also as those within the healthcare system, how we can pull the levers around value-based payment and value-based purchasing. This is kind of the snapshot of people might remember the July meeting where we did a visual recording of our action agenda. So this is the hard to read multi-page action agenda of different ideas that folks came up with. But then also we tried to do more of a visual. The goal here and the way that we were going to measure the success of our actions around this action agenda was around payment. So it really was focused on the Healthier Washington target that 80% of state finance contracts would be value-based by 2019. And then 30% of those state finance contracts would be value-based by 2017. That said, that this is a payment-focused target. We had multiple sort of domains within the action agenda, but we all recognized that in order to achieve that value-based target, that it took public health levers, equity lens, those within the social health, those entrepreneurs, as well as the more traditional healthcare sectors. And so I'm pleased to report that we got the data at the end of 2017 that we hit 30% of value-based payment in our state finance contracts in the 2016 year. We'll share what the progress was in 2017 and map that back to our action agenda once we have that data. But I think more importantly, that target is good to measure and it's good to track along the years. But more importantly, as you'll see in this action agenda, there was such rich action that was committed to. And even just talking to folks here in this room today, we accomplished a lot in the last year as individuals. And this is the future years data will be the culmination of of how we did that together. So before we start to think about kind of the shift from a value-based kind of action agenda that's really measured through payment to something that we're looking at the outcome of well-being, we wanted to go through an exercise today of looking through the action agenda, reflecting back on the commitments that you made, and just individual actions your organization took, and thinking about what worked well, what's still on your agenda in order to advance the actions that you identified, and then what are the barriers and the next steps that we should think about as we move forward to a well-being focused agenda. And also, what bright spots can we leverage? What worked well, as well as what didn't work so well. We had an internal staff meeting yesterday where we said, what was a good idea and still might be a good idea, but we would never do again. I would encourage us to kind of take that approach. So I'm going to open it up to the group, and we have mics being passed around to talk about some of the successes, challenges, and barriers for you and your organizations, as well as for Hillman as a group in advancing this action agenda focused on value. Who wants to go first? Great, Doug.
I will definitely validate that the VBC piece has worked tremendously well, and I think you know it's worked well from both sides, because the press for both providers to participate as well as for us to gain those contracts has really made a big difference. And when we look at it, we look at the outcomes from it. It's been tremendous. You know, where we get into those value-based contracts, and we're using data and we're giving information to the providers, we are seeing definitely things move. We're seeing quality move up. We're seeing HEDIS scores move up. We're seeing, actually, we're seeing savings in terms of the dollars as well, and we're seeing better health. So, you know, as an action for the entire state, having both sides of that equation being pressed towards that action, I think was great. I remember one of the first meetings I was in. Somebody stood up and said, well, someone's going to lose. Someone's going to gain money. Someone's going to lose money. I don't think it's actually worked that way. I think that, you know, everyone has kind of worked together, and the system's been shifted to some degree over it. So I really appreciate that piece of what we've done over the last couple of years.
Well, follow on to that. What's worked well, we have developed blueprints at the BREE for value-based payment with bundles, and also roadmaps for behavioral health integration, as well as opioid management. And all of those are part of the demonstration project. I think the real challenge will be how these are adapted at the ACH level, and how the commercial market will take these up as well. We have, as was mentioned, 114 patients at the centers of excellence who have gone through joint bundles, but the opportunity is much more in terms of better quality at a lower cost. So the real challenge, again, is implementation at the local level for these roadmaps and blueprints.
So turning our attention to community action.
So I think what worked well is we have a statewide common measure set that we've reported on for 3 years that came together in a 3-month time frame. Pretty remarkable community support to make that all happen. And we continued, I think, to lead the nation in that work. And I think we need to think about sustainability around that, how that evolves to meet the needs going forward of our state.
Bill, it looks like you might have something to say.
So when you think about how things evolve in life in the natural world, something has to change in order to force evolution. So the pH of the ocean changes and things evolve or whatever. And I'd suggest that the conversations that we've been having and the emphasis on value-based purchasing has created a different pH in the ocean where I can now have conversations inside multi-care with physicians about things that 4 years ago I couldn't have those conversations because there was not there just wasn't any reason to have those conversations. And so it's created a new environment to have conversations around BRIE Collaborative. I just had the other night all the orthopods who work for Multi-Care Health System in our employed group, and we had an in-depth conversation. I know nothing about orthopedic surgery, but they knew about the BRIE Collaborative stuff in the orthopedic surgery group. And we had a good conversation about that. That would not have happened without the BRIE Collaborative. It just wouldn't happen. And so well, it goes up and down, but you know, yeah, but it ended up. I mean, there were people saying, yeah, this ultimately makes sense. That wouldn't happen without kind of a community saying, we're changing the pH in the ocean. We're starting to have a different environment in which to work, and that forces evolution. And as much as I've been a transformational kind of thinker in my own career, my CFO has always said it always happens slower than you wish. And they've always been right with that. But evolution does grind, and we're starting to see that. So I think that's a success.
I have one that sort of fits both sides of the coin, I think, because as I think about what we have focused on, we have focused, in my opinion, a lot still on the healthcare side, the medical side of the house. And I would argue, and I think it's beginning to be articulated here, that we really need to pay more attention to the community side and the social determinants of health. And where I think this kind of sort of goes on both ends is health equity. So we have worked pretty diligently on not forgetting about that. It's come up multiple times, right? But we haven't really found a really good way yet to actualize reducing health disparities. We're working on that. We have a committee working on that. We have subgroups working on that. So that's the good news, right? We're trying to figure it out. But what's next? We really need to pay more attention to that, in my opinion. And I invite you all to help us do that. I happen to be a co-chair of that said committee.
Thanks, Winfried.
Winfried, you're looking for more projects and just more work to do. So Sue, I really appreciated your words. Of course, we're in Summit Pacific in our critical access hospital, one of the sickest counties in the state. We have our work cut out for us. Not being a part of the Helm group, I can't speak to what you've done, but really building on a piece of what Sue said and what you're saying, Winfried, is our focus on the region and the economic basis of it and how as healthcare we can be a lever for that. And then moving beyond just the data sets that we are traditionally used to looking at and looking at wellness. How do you measure that entire mind-body connection and your relationship to your community and all of the different connections that are inherently there? So I would ask the question of the Helm, is that the direction that you're seeking? And that might be what we're talking about later.
Yeah, and Tammy, I think that's a good point. And when we were thinking as a team with Bill and Sue about how this shifts the direction or not, it was really clear to everyone, at least on the Healthcare Authority team, that we've been talking about well-being, social determinants, a healthier Washington all along. We've just been entering it through a payment lens, which then makes it really through a framework of the healthcare delivery system. And so I see this shift as from last year's action agenda to this year's action agenda being really more of an evolution of our frame of mind more than anything else.
People on the phone. I think you're getting there also with the multi-payer model. So you can't have this conversation in the MVP team, and there's been other tables, and I see nods. Great relationship with Melina. Thank you, and AmeriGroup. Fantastic. We've just done really well in our small corner of the state, but you've got to be able to have all the payers at the table, at least multiple payers.
So this conversation is mainly about data and metrics, which is, I think, in a way appropriate for the beginning phases of this kind of transformative effort. But you got to talk to the people who are experiencing it. And I think it's what I haven't heard yet is ways to get informed communication with the consumers, with the Medicaid recipients, and with people who are in the system to find out how they're experiencing it, whether they are perceiving this as a positive change, whether the changes in care are actually affecting their wellness. So I would encourage us, and I think it relates to what Winfried was saying about equity. I mean, if you don't talk to people about how they're experiencing it, you're not going to get very far along that path.
Thank you. We'll do, Jürgen first, then Molly.
Okay. I have two comments. One of them has to do with the mention of Cuba. I've also had a chance to spend some time there, and it is exactly how you described it. It's a experience that all of us should be able to have, because it really makes you think, what are we doing with all this money? You know, that 20% of the GDP that we're spending on our healthcare, which is great because it helps us all pay our mortgages, and that house you bid on, that requires a mortgage. But it's really important for us to sort of have the guts to say, if we want to take on this bloat stuff, we need to make a not to-do list. You know, every one of us goes to meetings all day long, and every one of the meetings you walk out with a to-do list, and we never really have a good process for to say what really is the not to-do list, and how can we really work a not to-do list. Making a not to-do list means we're telling people who are paying their mortgages with something that they feel good about, that there's something better. Of course, that's really challenging. How do we support that? That's a generic comment. The other one has to do with, I think the challenge of bringing the social services and the health services together is enormous. I think we all know this. We spend way too much money on the healthcare side, on the downstream stuff. And so I'm wondering if we could pick one or two sort of indicator conditions, in sort of things that could really make a difference. So for example, there are 96 or 98,000 births in the state of Washington every year. Exactly half of them are paid for by Medicaid. And I'm going to say there's probably 10 or 15,000 of these births that we would all agree on are super high risk situations. These are moms who live in true poverty, who don't have the support they need. They are addicted to opioids, maybe they're depressed. But 10,000 is it's not an unlimited number. It's a thing we could do something about. It's not, unreachable. So what if we made a serious commitment to say we're going to find these 10,000 people and we're going to pull all the stops out and see what's possible when we help them with their addiction, when we help them with depression, when we help them with the money they need so they don't have to do other things that are really bad for them and their families. That, to me, would be a tangible goal that everybody in every community could get their head around, because these moms are in every community. Something sort of very specific, very exciting that we could get behind.
And I just want to build on what Bill and Janet said both. I think the exchange is a really small piece, just the individual insurance market, but we do have a bipartisan board. And we have lived in this world where we've been very much focused on kind of the cost of premiums and who's offering in what county. But our bipartisan board is now saying, how do we address the underlying cost of care and how do we get there? And there's a lot of interest in the value-based purchasing kind of arena. So we're partnering with Rachel and HCA to try to get more involved in this work and really have the board play a bigger role. I think something that the exchange can do is also has an interface with a consumer, and as we've tried to kind of make things more digestible for consumers, is also trying to help educate consumers around what is value-based purchasing and how they benefit from it. And so that's something else that we're looking forward to engaging more in.
We're going to do Diane.
Oh, no, Virginia first.
Thank you. Diane Sosny, SEIU Healthcare 1199 Northwest. I like a number of the ideas here, but I really think your idea about tackling a definable population that we can really get our hands around makes a lot of sense and would be a great project. I also think on the comment over there about the focusing more on the social determinants, last night I looked through this document, and I don't think, maybe it's come up here, but I'm not sure I remember the issue of homelessness as part of thinking about the social determinants. And it touches every community. It's not only huge in Seattle and King County, and there is now one table being set by the mayor and the county exec. But I know, because our members work in other parts of the state, where it is growing or big in other counties. It's sometimes a little daunting to think about how we completely solve it in Seattle, King County, but if there was another part of the state, a county, and some areas where we could think about it, I think that might be along the lines of, can we demonstrate something on a smaller scale, but would have the same characteristics that we could apply in a bigger place. The amount of resources that are going into just trying to prop up and deal with sort of the emergent or the emergencies that happen every day, the waste of dollars at the front end in dealing with homelessness and healthcare issues and behavioral health issues is unbelievable. And we don't have anything to show for it because it's very siloed, and we're trying to think about how we bring together these different parts of the service system, if you will, or non-system, to achieve a certain outcome. And I don't think we can talk about, this is our perspective and our members' perspective who are on the front lines of dealing with homelessness, a healthier state or a healthier Washington without talking about homelessness.
Okay, I wanted to just give a brief update on a value-based payment success that has been going on in the last 6 to 8 months, and this is the Value-Based Payment Practice Transformation Academy that my organization is sponsoring with the National Council for Behavioral Health for community behavioral health agencies here in Washington. And we have 20 agencies now that are halfway through this academy. And our goal is to prepare these practices for effective work in a value-based payment setting. And I think, given all of the comments that have been made, I can't overstate the importance of these community-based organizations as partners in successful whole person care and as linkages between the healthcare delivery system and social determinants of health. We have always been community-based. We have always dealt with housing and poverty and basic human needs. And so these providers are living in both of those worlds, and having them be ready to operate in a value-based payment approach is critical. So we're moving along. It's been a great partnership with Healthier Washington, with the Practice Transformation Support Hub, We were able to secure funding to continue the academy through phase 2 by working with DBHR and the Transforming Clinical Practices Initiative. I think our deliverables will be a Washington state specific curriculum and tools that can be used by others, how to go about value-based planning within your organization. And our challenges are, how can we replicate this academy experience for other community behavioral health agencies so that the entire sector is ready and able to be strong partners? Thanks.
So the one thing we haven't really talked about are the accountable communities of health. And I think they really do have a great deal of promise. I've been involved in our North Sound ACH since the very beginning, since pre-waiver days. And, you know, thinking back on the pre-waiver days, what was really at the heart of our conversation was wellness, population health, social determinants of health. And, you know, the waiver is great, but I think it's kind of been a distraction in some ways from really having us get to the heart of what we really want to do in Washington State and in our region and in our communities. So they really do show a lot of promise. I mean, just the power that's around the table. And I know in our ACH region, we've proposed to put aside some of the waiver dollars to focus on projects related to social determinants, population health. You know, it's just a small amount. And really, when we have the conversations, that's what everybody at the table, regardless of, you know, what sector they're coming from, that's what everyone wants to really focus on. So I think there's great potential. I'm hoping that, you know, we can get over focusing on all of the waiver requirements, because that's really all we've been doing for the last year and a half. And then really focus on how are we going to sustain the accountable communities of health, because there's really great promise. I see it for our region. So anyway, that's my comment.
Yeah, it takes a really multi-dimensional approach. We'll go here, and then Diane, you'll get the last word for this conversation.
So, Aaron Spark from the Seattle Indian Health Board. So I do want to point out to the barriers, and I feel like we didn't touch it very early on, but these are good things to talk about because these are things that we're struggling through, even as we're working through our time with the ACH. But some of those, and from the provider's perspective, is we still don't have good access to care, timeliness to care for our clients who are Medicaid once they're out of primary care. The other piece of that is also we're still not at the point where primary care is preventative medicine yet. I think once we're there, then we're talking about the actual savings that we're getting to. So I think a lot of the emphasis was just getting people covered at one point, but not necessarily getting them to the 1 or the 2 visits that they have a year, and not really getting to the point where they're thinking about their health care as something that's a full-time job for them as well. So I point out to them as barriers, but something that we can actually work on for what's next. And I would say that there's some very bright spots right here, because some of these conversations that we're having have led to change and systems level change. Like in the city of Seattle, we got to the point where homelessness was talked about in our directed communities or targeted communities. So now we actually have this push where, you know, 3 of our organizations got dollars directly to combat homelessness for our American Indian Alaska Native people, but it's also for everybody that we serve. I mean, Seattle Indian Health Board is still at 3:30, so our doors are open to everybody. So these are some good things that are happening out there, but I'm really happy to hear that we're going to start marrying this aspect of healthcare economics with what we're doing. But something that I'd really like to do, and backing up what Janet was saying, is making sure that's directed by the beneficiaries of health of Medicaid. Because I think Janet and I have been saying this a lot in our health equity piece, is that we're just not seeing that in a lot of these different groups that we're sitting in. None of us are Medicaid beneficiaries. I have no idea what it is to live under Medicaid banner. I don't know what it is to wake up to say that this is what I need to do. And I can say that as a community health center, when people walk into our place, they're not asking us about who their coverage is, who's paying for this. They're coming to us because they trust that we know how to take care of them. And a lot of times when they walk out, despite some of the aspects, despite some of the education programs we have, they don't know what their coverage is. They don't know how they're getting paid for their medical care. And when there are these changes, and we don't have every payer at the table, and there is and we have an upset in their coverage or their network, they will walk away from healthcare at that point. All the work that we had just to get them in the door is immediately gone. So the things that we can work on as we're going forward, and I say that we do, and we have made huge strides, but there is still a lot of work to do.
Thank you.
I really appreciate the turn of the conversation toward social determinants of health, and thank you, Winfried, for continuing to focus on equity and for speaking to the CBOs and the ecosystem and special strengths that they bring. But I think there's one thing that we definitely still need to continue talking about. There's so many, but race is one of them. When we look at, what are some of the indicators that we should be looking at for any system outcome, I believe it's reduction in racial disparities, other disparities as well, gender disparities, income disparities, but we have to talk about race. And I think we also need to further diversify ourselves here to make sure that we're bringing the insights of people from those communities on how you actualize equity and use a racial equity lens. But it has to be a focus because the rising tide does not lift all boats. We know that. We see that every day. And with all of the, all the rhetoric that's now so common from the federal level about race in a very negative way, I think it's just a key time for us to lift that up, focus on it, and really home in on ways to reduce racial disparities. I don't think we can have a successful system without it. If you look at our demographics as a nation, we are becoming a more multiracial country, and that is part of what the immigration debate is about. That is what part of the pushback on the white supremacists is about. If you look at our state, we are becoming a much more multiracial state. If you look at our city and counties, that is the case. We cannot have a successful system through whichever lens you look at it, whether it's value-based payment or whether it's social determinants, whether it's quality of care, without addressing race. So I hope this year we can spend more time on that.
Thank you. And thanks for the, yes, let's get a mic.
Thank you, Diane. I'm really glad you said that. And I think connected to it, and we've talked about it a little bit, but I think it does need to be highlighted. I totally agree with you that we have to elevate race and talk about it and have that be representative of who we are in this state, sitting at a leadership table as well. But drilling down, and I know we have subgroup on this, is around workforce. And I think one of the ways we absolutely get at getting to racial equity, organizational equity, and inclusion is that we ensure that we have a workforce that looks like the patients we're taking care of, who speak the languages, same backgrounds, cultural norms, etc. And our organization is trying to make our contribution in terms of, and MultiCare is a leading partner in this, as well as other health systems, but a training and education fund that really is disproportionately, I would say proudly, having service workers of color, many of whom are foreign born, come through the training fund, become nurses, become other, move up the career ladder in healthcare as providers. And I think we should be looking at this work with that lens as well.
Thank you. And thanks for the reflections. I do think it's important to look back in order to move forward. We've set the table well for our conversation after the break to really talk about how do we continue to build upon what's working well and what we also need to focus on more deliberately in order to move toward an agenda that could focus us and also focus on well-being broadly. So When we come back, after a 10-minute break, please refill your coffees and answer an email. When we come back, we'll talk a little bit more about what this action agenda could look like, and then we'll also have the opportunity to kind of get up and move around and contribute some ideas in a more interactive way. So 10 minutes, which looks like, I can't read my watch. I'll let you know. Short break. This is your 2-minute warning to get a cup of water, take a seat. All right, everyone, please take a seat. We're coming back together. You too.
Okay, we're going to start in 1 more minute. Okay, I think We're going to spend a little time now getting much more actionable. John, I think you should come join us. Try chairs. So I think you guys gather from all the comments, and we would all agree that this state has really done a lot in stabilizing coverage, trying to really make sure that access is acceptable. But I will just tell you that from where I sit, I'm very concerned about rural frontier zones, because I know we don't really have the type of access standardization that is acceptable to me, but we'll be working on that more. And then I love that we truly we have this movement with the behavioral health integration into primary care. So these advances on the delivery system really have been supported and are baking in, you know, I like to liken all of this to kind of a progression. And I'm such a foodie coming from a Hungarian family, but we got stuff in the oven, that's for sure. And financing, data, the information exchange, the clinical community linkages are beginning. It's just going in the oven. And I think we need to have some more discussion about how do we get actionable to really make sure that we've got the right amount of time of stuff being in the oven and the right amount of heat. And what do we need to do in these kind of arenas as we keep journeying on forward, creating a healthier Washington? Bill?
I like to think about the journey we're on as actually, say, a social transformation of the health status of our region, because social transformation is a lot more powerful than just trying to force somebody to do something. And we saw that in very interesting ways in the United States around, say, tobacco use, around the idea that we can actually talk about breast cancer. That was a huge social transformation when Betty Ford actually went public. She had breast cancer. So we have a lot of women today in our society who have had successful early diagnosis and treatment of breast cancer because Betty Ford started a social transformation around the acceptability of talking about breast cancer, which is a social transformation that happened in that space. Same thing around tobacco use. Tobacco use, actually, the most powerful thing was that it became largely unacceptable in society to be a tobacco user. That's what largely moved. It wasn't the education. We all knew it killed us by the time the Surgeon General came out with that, but it was the social transformation that happened. I think that's what we're trying to engender together as we think about moving us from a community that is probably not as healthy as we ought to be to a healthier Washington. So I think that's really, really powerful. As we think about an action agenda, though, I use a rubric in my own organization that I say to people, when you're thinking about a problem, what's your sphere of accountability? So what can we be, what is our sphere of influence, and what's our sphere of interest? Let me use an illustration with that. So I happen to be fascinated by plate tectonics. You know what plate tectonics is, you know, how the continents move around. I have zero accountability in that space. I have no influence. I just have interest. And so it's important for us to know where we're going to fit in this. So when we're creating an agenda for well-being, it's kind of important to understand where we're going to play in those spaces. So as a person who works in business, my sense of things is that I have a different role than maybe I was brought up to think about inside healthcare. I was a deliverer of healthcare for a lot of my career. But as an employer, what is my role? It's to have a healthy workforce as opposed to a well-consuming workforce, consumer of healthcare. And so I actually have both interest, influence, and accountability in that space. And I'd suggest businesses, I'm not government, but businesses, we ought to think about a broader perspective around this journey than maybe we have traditionally thought about in terms of our role. So I'm just trying to define for myself that I have three things there. I'm interested, I have some influence, and I have some accountability in that space. Now, depending on where you are or where what your role is, you may have different pieces in that. And so as we create a action agenda, I think it might be interesting to sort through where we think we're going to play in the space as we identify action agenda items.
Yeah, so you'll note from my leanings that I also want to start targeting where we can create some successes, but that we really move the needle. And so I think there's been already some very significant interest in this bundle concept and successes here in the state. You know, joint replacements aren't necessarily a big mover in the Medicaid world, but what is a big mover are healthy babies. So I've asked my team to start thinking about how we can look at things in a life stage, because whether you're in a hospital or a nursing home or a public health agency, it marries up really well with the success sequence. So one of the things I think that could get very actionable as we start looking at life stage work is this notion of creating some sort of maternal child mom baby bundle. And I know a lot of our commercials have some of this going on already, but for Medicaid, I think it would be a wise investment. And I know my UW friends are chomping at the bit to look at something like that.
Well, that marries up very well with the comment earlier about the 15,000 Medicaid moms who have significant social determinants of health challenges, which has a direct impact to the health of the babies that my own organization, we deliver a lot of babies in that space, and it's a significant challenge. So but are there others besides? I mean, this is really could be discrete. It could be really interesting. It would have a real impact lifelong on the kids who are being born in our community. So that's one. I like that one.
And this is for all of you. I mean, we're just looking here right now to think about what are the other actionable things we can do to really start solidifying more of this culture of health and well-being, and where do you see opportunities, or where do you think both public and private need to go? Yeah.
Have we thought about the global health organizations around Washington State? We have 200 organizations working on a number of different avenues. I mean, global maternal health, I think about PATH. I think about the folks, Gates, yes, on the funding, but the GAPS, Global Alliance for Preventing Premature Stillborn, something, GAPS. I'm just curious about that linkage to some of the partners that work internationally, but could also be part of the conversation locally.
Thank you.
I bet my staff could make comment about that, but I haven't heard of those particular global partners yet. But I think one of the things we have to keep keeping in mind is this notion of new network leadership, how the hub issue becomes, you know, maternal child well-being, and that advancing on lot more value kind of birth experiences and or first life stage successes. And then how do you get everybody, whether you're a hospital or federally qualified health center or employer, how do you get everybody on board with really laser focus, moving into more effective? Yeah. Yeah.
Building on that a little as well, it's my responsibility to continue to look through the rural lens. And Joe and I were just talking, when we talk about inequities, we talk about high-risk pregnancies, and I consider in my county, we may lose OB completely in terms of a presence in the next 6 months. So unless you're willing to fly those high-risk moms out of our county, at what cost, I would challenge you to think a little bit, how, again, away from the I-5 corridor in that, and I look at rural medicine as its own inequity.
You're absolutely right. And, you know, we've seen, again, in many other countries where they actually do maternal housing for the last 6 weeks of the pregnancy period to get those folks closer, so then they don't have the high risk, they take down the high riskiness. So getting our housing partners to think about how we create some maternal child housing opportunities. I think our friends at United are doing some really interesting things down in Arizona as well. I don't know, Doug, if you want to talk about that a little bit, but.
It's a really whoever. Okay. It's really a public-private investment, and we're actually doing it in several places around the country. It's in Arizona, where we've actually put money into a housing piece, 100-unit housing piece, and actually it's more than 100 units. We're also doing it in Hawaii, we're also doing it in California, and we have targeted Seattle as another place that we're going to enter, and there's about 6 other places around the country. So it's not, purely just putting dollars into it, but it's also looking at how we manage housing and how we intervene on a more social aspect of things, not just with the dollars towards housing, but also the benefit and other like sort of things that we will put together. So a housing coordinator that may help with housing, help with those connections, becomes part of our clinical team, and works with an individual around housing. So just a whole set of things that we're doing.
In Connecticut, they're doing quite a bit with very successful telehealth initiatives. I know everybody knows about Project Echo, but they're really reducing the unnecessary procedures and reducing the time to specialty services down to like less than 2 weeks for the Medicaid population, because they are using basically centers of excellence, telehealth hubs around the nation that are really producing some great successes. So it's another thing that we'll be looking at too for telehealth. And I understand UW just entered into a very significant partnership with RCCH. I think that's public information. So we'll be following that and meeting soon with the leadership there.
So hi, I'm David Stillman here on behalf of Cheryl Strange, DSHS. I happen to serve as the Assistant Secretary for Economic Services, so food assistance, TANF, child support enforcement, disability determinations, refugee cash assistance, and a few other things. We serve about 1 in 3 Washingtonians through those economic cash and food programs. So y'all are singing music that resonates in my heart when you talk about social determinants of health and the supports that families and individuals need in order to be healthy, to live in a community where their wellness is not just comprised of health care, but all those other pieces that are so critically important. And I had sort of said to myself I wasn't going to talk, and then the questions got asked. I think it's interesting for me to walk in this room the first time, and if Cheryl asked me to come back, I'll be grateful. What I notice is that there isn't a lot of the social determinant of health representation in this room. So you don't have a coordinated entry person from a county. I hear a lot about homelessness and housing, and I appreciated those comments. But if you're going to have a systems conversation about prioritizing resource deployment, not necessarily adding new money, but finding a way to braid and align the work that we do, where's that person? I look at the list, I don't find that, Commerce is represented, and they have a role, significant role around that, but a county person I think would be really important, regardless of whether it was a rural one or a large one. I don't see someone here another piece that doesn't often get talked about, and yet it's a huge cost center: transportation. Getting to and from those appointments, not just the, non-emergent Medicaid transportation. Not my area, right? But I don't see that as something that's being discussed or talked about. And I think that's a really significant issue for poverty as much as it is for this health conversation that we're having. I also think that employment, it would be great to have employment security, or maybe somebody from the workforce board or some voices that are around that piece. I think the time is right. You guys have been meeting for several years, and you've worked on this other piece, mostly related to the payment system, but I urge some consideration to be given. I'm going to say this, and hopefully it isn't offensive. Bring in some new genetic material to the conversation. You change the pH level. Let's bring in some other pieces and think about how the environment continues to evolve. That would be my observation.
So if I can jump in here, I heard a lot in the last conversation about the interest in focusing on something a little bit more concrete as far as a population or an outcome. We have an example, sort of healthy youth episode up here. Sue talked about babies, and I'm sure that there are others. Is there interest in digging into one or two sort of specific kind of populations or episodes or bundles, however we kind of want to frame it, as a health innovation leadership network.
So we've suggested maybe one to look at would be, say, adolescence. You know, if you start with a healthy start, it's a lot easier to have a healthy adulthood. And so in my own organization, we're thinking kids is a really important place for us to connect as in our communities. And there's a lot of things that play into that actually we can all have influence on, interest in, and some accountability for. I'm really interested in that space because adult behavior doesn't change very easy. I don't know if you noticed that, but my habits don't change very easily. But if you can get kids to start with a different perspective on health and a different way of living, it lasts through a lifetime generally. So that's that might be an area to think about. So we have maternal child, kids with, you know, the 15,000 with challenges, maybe kids, maybe adolescents. It's all in the same geography there.
Well, you know, not to cheat, but Sue, it sounds like you've got with your success sequence a pathway that we could use, and you've already done it.
We shared it with you guys about 3 years ago.
Right, but why couldn't we make that one of our goals is to look at you know, that whole issue around teenage pregnancy and educating those folks and looking for the same kind of outcomes that Colorado reached.
Did you do anything with an effort with the schools in particular? So we are looking at any opportunity to partner with the school districts in Grace Harbor County in order to really push any kind of healthcare delivery, but also the behavioral stuff. And I guess, Bill, that's a little bit where you're going, is how do you start to invest in adolescents and in school-age children to instill healthy behaviors? So in this program, did you?
Seen one Medicaid program in this country, you've seen one. So every landscape is so different. So in Colorado, the federally qualified health centers and then the school health program, school-based health centers have a strong hold. So we kind of did a leapfrog approach of we were provider agnostic, whether it's OBs or pediatricians or school-based centers. We created the landscape for the funding reforms like you all have done in VBP in your progression. And we reached to all service delivery sites, whether you were a public health Title X program or that OBGYN, we made it available for you to go through a practice transformation effort with us. We didn't look at building more capacity just because, interestingly enough, you know, I think there was a lot of concern that there just weren't going to be enough doctors to take the big surge of all the expansion populations and all the new activity with the ACA, and that did not come to bear. We were able, in fact, the most recent report in Colorado showed that people were pretty thrilled that they could get into primary care within 1 to 2 weeks, and specialty care. Specialty care in rural frontier is, again, payer, regardless of what payer you are, it's usually a big issue and you're usually traveling in for specialty care. So specialty care in this country is a big issue across the board. It didn't really build the capacity specific to the schools because I think unlike Washington, Colorado is very different, a lot more local control. So some school districts will have nothing to do with reproductive health. They don't even have articulated school health curriculum in some areas. So we kind of leapfrogged and said, let's plant it everywhere we can in the primary care environments.
You're running in an open door here as far as Cascade Pacific Action Alliance is concerned. Our accountable community of health, we have an extremely high youth focus, sort of mirroring what was said earlier. When we got together 4 years ago now, when we thought about as a community, as a region, how do we get to better health? We landed in exactly this space that we need to work focused with youth. And we have actually a pilot project that we've worked on now for 2 years. And I just want to make sure that you're well aware of this project. which is focused on school-aged youth that have unmet behavioral health needs. And we started this in one community in southwestern Washington, and it's now been replicated in 3 other communities. And the initial indications are that this work, once you truly assess what are the needs, not just medical needs, but also social support needs of kids, and then you make a targeted effort to coordinate care across the spectrum, again, social and clinical needs, it works. And we have early indications that graduation rates, we can't really talk about yet, but certainly truancy rates are dropping, that kids are in school more, that math and reading scores are increasing quite significantly. So it's not necessarily, that's all driven by this project, but I think it's a contribution to these outcomes. So I would strongly support the focus on youth, and if we could sort of get the additional lift that you all represent through your expertise and aligned resources, to really look at this, could we expand this potentially? I would be very, very grateful. Our region would be really grateful.
John Weisman, Department of Health. So I'm very excited about this possibility around the MCH bundle. And because it's come up a couple of times in the last few days, something, I guess, making people aware of a couple of things. First of all, some folks probably know that the Hospital Association has had a Safe Deliveries Roadmap project. So Sue, I just sent you the link. That's why I had my computer out so that you could check that out. But there's also something which is sort of in the quiet phase, has not been fully made public, but it is starting up. So there is a public-private partnership that has been formed here in Washington State around increasing access to the full range of contraceptives, particularly LARC. So the state is pairing up with Upstream USA, which is a nonprofit organization who has received the philanthropical monies needed for a 5-year effort to work here in the state, essentially kind of replicating some of what Sue was talking about, and has hired an executive director and is quietly sort of working with the State Department of Health to get early adopter clinics. They basically go in to work with clinical systems to do everything from how you ask patients about the contraceptive interest at the moment to the billing changes and the practice transformation needed. So I think the time would be really great to have like an MCH kind of bundle, because with these other things going on, I think we're just set up for this great success. So I really like that a lot.
Can I just tell you, spoiler alert, the one question is, do you want to have a baby in the next 2 years?
Right.
And anybody that says, hell no, there's a whole different algorithm and protocol where you move into consumerism, and it's just fascinating to see how this comes together. Very neat.
And that's part of the training in the clinics as well, is it's the question that gets asked like at every visit. So all of that is so being incorporated into this.
Similar to what Maryland taught many of us in the country that were experiencing huge suicide epidemics, which was ask people, are you going to kill yourself? Are you going to take your life? And that opened doors to, okay, now we need to move into, this algorithm of service.
Indeed.
Just Phil Colmenares, Primera, a comment about the social determinants of health and the power of data and the whole idea of changing the pH. There is power in transparency, and I just wonder, a lot of us know about the Commonwealth Fund when they compare the US healthcare system to other systems, and we spend twice as much as other countries. One of the data points that they show also, though, is they compare that with how much each country spends on social determinants of health or social services, and it's powerful to see that and that contrast. So I wonder whether we either use the Commonwealth Fund ratio for each of the states and compare our state to other states as just a way to highlight how much is spent on the social determinants of health and social equity and those kind of things, and maybe use it as a North Star sort of thing.
So this state participates heavily in the Milbank Fund with your representative Cody, and so there's a whole project on total cost of care and getting that proportionality of health to human services funding. I mean, there's this whole notion of getting kind of a rubric around what's true total cost of care, and then what within that cost, where does it sit and where do we need to go? So I totally hear you. That notion of 2/3 right now being spent on medical to 1/3 social is the wrong ratio, and we have to flip that as well. That's going to take some time. Yeah.
I don't see mentioned up here what you were talking about earlier for your analytic needs, which is as a follow-on to the transparency. But I would really like to see an action agenda built around getting a statewide dashboard for both the health of the state. Our current system is very fragmented with we have a common measure set. We have the Washington Alliance, which is reporting broadly. We have a all payer claims database, but they don't seem to be married. We also have measures of social determinants. So I would want, and can we marry those metrics into a common database for health, social determinants, workforce diversity that would guide us as we develop these innovations? Because right now we don't know where we are to a great extent in terms of our success and the rigor of our implementation of innovation.
Yeah, so the UK and Richard Reeves shared the Brookings model of the social genome mapping, and Colorado did adapt it, and our team's kind of looking at that. And again, life stage approach to what are those right health and social metrics that could be kind of a backbone for the ACHs. They're pretty non-medical, so I know the pediatricians will have a heart attack when they look at some of those things. But anyways, lots of good work starting to generate in that area as well. Yeah.
So related to the issue on early prevention and contraception, the fact is that our state has, I don't know if it's the most in the country, healthcare under Catholic control or religious control. And as more mergers, I just read a report on a review of last year, the number of mergers and acquisitions. You mentioned RCCH and the university, which is interesting because that's a for-profit system getting together with the University of Washington. But, excuse me, Catholic healthcare has been merging, and the prediction is that in 2018, we will continue to see some, major mergers. So, I just put that out there because there are a number of people who are concerned about this issue in terms of things like contraceptive care and how we address that. And I don't know if this is the right term or not, but do a workaround. Yeah.
In Colorado, the largest system was a Catholic system, and it didn't dent our success. It didn't stop us. They created workarounds that were acceptable to everybody. So we still have those good grades. Made it work. But okay, you're way back here. I'm so sorry.
That's okay. It's Sherry. Everybody knows me. I'm usually the consumer voice hiding back here in the corner. So I like to look at the journey that people take through life and through their healthcare system. And in the last couple of years, I've discovered that women my age are family caregivers. There's 48 million family caregivers in the United States. They're actually the biggest group of providers in the country. And we provide little or no support. We don't give them training, emotional support. It's the number one reason women quit working in their 40s and 50s. And they provide great benefit by taking care of seniors, children across the board. And they're not really in this conversation yet. And so I'd love to see sort of that demographic. 40% of caregivers are men, 25% of them are millennials. Kids come home from college and are taking care of their grandparents. And it just sort of happens, behind the scenes. And so I think that that's a whole intersection with social determinants of health, with economic development, with our healthcare system that follows the person and their family instead of a disease that we could bring into this conversation.
Great point. Thank you. John.
Another great opportunity we have at the moment. So I think the timing of all these things coming together is actually pretty incredible and powerful. The state health assessment is going to be released probably in the next, I think, month. Some of you may have been one of those 700 recipients who got a copy and were asked to comment on that. So that assessment's going to be out soon. I think we've reviewed all the comments and are making final edits to that. It takes a broad look at health. The second piece to that is a state health improvement plan follows this. And so everything we are talking here about dashboards, about social determinants, we've got an amazing opportunity, I think, to marry the Healthier Washington work and this health improvement plan to help get the focus and the priorities and the innovation, and thinking both from a determinants of health model as well as the life course. So I think this is all going to be great timing to keep moving us forward.
Other comments, other ideas?
One of the things that I really like about the maternal child health focus, first of all, it's pretty foundational to society, which is interesting. I like to kind of get the root of things. But one of the things is that it actually will force us to think about maternal health. So I work in an organization that has a lot of complex care, and we have two major drivers of difficulties in maternal child health. One is opioid use, which is a huge problem in our society, and so that would lead us into some conversation around that. The other is, which is actually more significant, which I don't know that we've ever put it on the table, it is maternal body mass index. So we have a very large challenge. The BMI in a mother is a major driver of risk factors for kids. And we don't, I mean, that's hard to put on the table, but the truth is, if we're going to deal with maternal child health, we're going to have to talk about that as well in our society, which is also foundational. Let's face it, diabetes. There's a whole range of things that tie to a healthy weight.
John and I were at a meeting yesterday where there was a strong voice of food is medicine, and we were tying in those themes about food because of the need probably for an integrated eligibility system. I know in Colorado we built out one of the first. We didn't just screen for health, whereas the exchange we screened also for nutritional needs right away, and we also screened for work supports right away.
And we sometimes think primary care is what physicians and providers do. I heard the dean of the School of Medicine for University of Maryland once talk. He said, we forget that lifestyle is primary care. And so that takes in food and exercise and healthy behaviors and a whole set of things, which actually drives what, 80% of what we deal with in the healthcare system is related in some way to how we live. So,
Joe, I think you had a hand up.
Yes, I'm struggling a little bit because the focus on maternal child health in our discussions in our community of health is that we recognize the value and importance of that, but also it gets into preventative work, and it gets into really, if you're going to do value-based contracting, you're not going to see the outcomes for generations. And so this whole idea of amping and putting money into that, at least based on the limited funds that we're receiving in our ACH, is that we decided to take that off the table for the most part, because we're really restricted to try to get the biggest, strongest bang for the transformational buck that we're getting. So that I hear what y'all are saying, and I obviously wholeheartedly support it. But also what I'm trying to say that application-wise, at least for some of us out in the providers realm, we're trying to set some of this modes into action. I would love to see some recipes for making this work more effectively, efficiently, and have a faster evaluation or assessment of that. And that leads me to my next issue would be, we are, I guess by title of this group, health innovators and leaders. But there's also the question of, what can we do to support innovative and disruptive proposals or projects across the state? In this, there's so many different avenues and cultures and communities across the state doing different things, and we have a tendency to homogenize our thinking for innovation and disruption. And I find that really concerning because of the fact that it takes us out of touch of the people in the communities that we are providing that services to, who I believe we should be listening to more so rather than telling to and talking to. And I like to see perhaps more of a focus of that level of engagement as we have, we have what I guess is a sole individual in the back who professes to be one of a person, participant in the healthcare community. But I just really would, I'm not seeing or hearing a whole lot of gee whiz. If we're going to interrupt, if we're going to really disrupt, if we're really going to innovate, here are some ideas. Let's underline them. Let's run them, and let's learn from our mistakes. Let's learn from our failures. And I'm not really hearing a whole lot focusing on those type of opportunities. The opportunity to fail gives us the opportunity to learn and to go forward, in my opinion. And that's where the innovation and the leadership should be focused and going towards. Just my 2 cents.
Joe, thank you for those comments, but I would push back a little bit to say it's pretty hard with SIM and federal money to fail and then expect to get your next year's grant. But that is why we are very excited about the private philanthropy dollars that come in. So upstream, as John said, and it was a little bit why Mr. Buffett made his move of, hey, Washington University, in St. Louis and Colorado, go quietly with us on this social engineering journey around LARCs. Use our money. If you fail, so be it, but let's keep it kind of quiet while we make the grade, and then we splashed bigger into the political realm. Had we splashed initially with government money on some of the work that's been or being done, I can tell you that some of our legislators would crush things faster than they already do. If you knew all the things we threw at them. So a little pushback on that first part, but hear you loud and clear that right now the way the ACHs are being incented, it's how it began, but things will evolve and mature as we bring other resources and sustainability to bear, because I think it's a progression and it takes time. You got to start somewhere. And I will think about your second point. And I will tell you, I was really pleased with Joe Selby at PCORI giving us in Colorado some extra special attention. And we brought in the Institute for Person and Family Centeredness to do a complete evaluation on state government of how non-whole person centered we were. And it gave us a grounding place to form a council of clients. And they are, they're not militant, they're fabulous, but they're a real driver in Colorado. And so we'll probably be looking at how do we, again, really embolden this whole notion of whole person and person-centeredness.
So Colorado also brought in the certified community behavioral health centers. You're one of 6 states in the nation, I believe, that took that effort on. It's something that we in Washington looked at, tried to, from providers, tried to push forward. We're unsuccessful. But that's also taking at least behavioral health to a federal level of accountability and action. So there's different things that I believe I would recommend putting on the table for us to continue to explore.
So, Laura, you'll capture that about the CMHCs.
And I just wanted to apologize. I guess everybody in the room didn't know who I was. So I'm Sherry Reynolds. I'm the director of the Center for Health Innovation. I co-founded the Consumer Advisory Group for the Puget Sound Health Alliance, now the Washington State Health Alliance. I was the National Project Director for Health and Human Services, Office of the National Coordinator in charge of provider adoption of patient-centered health IT for the country. I worked with 147,000 physicians, getting them to do patient-centered design. So I am the person in the back of the room, but I have some local gravitas as well.
So if I could just pick up on some of what we've heard around the table, as the head of the University of Washington State Innovation Model Evaluation Team, just focused on SIM, not in the entire Healthier Washington effort, I wanted to point out the equity lens. I think that's something that we are trying to take very seriously at the university. And I know Alan Cheadle and his colleagues at the Kaiser Permanente Washington Research Institute for their Center for Community Health Evaluation are also putting as much of an equity lens as they can on the good work they're doing in evaluating the ACHs. And Dave Mancuso and colleagues at RDA, the Research and Data Analysis Division of DSHS, are incorporating this in their important work about that first payment model that's been implemented in Southwest Washington. I just wanted to say from a UW perspective, my colleagues, Dave Grabowski and myself, are trying, as we look at the encounter to value payment model, as we look at the accountable care program, and as we look at the integrated data solution that's being developed for the FQHCs and the other kinds of entities, like in particular Summit Pacific and Northwest Physician Network have stepped up on this. We are trying to put, to the extent we can, with the kind of claims data that we have and the other data available to us, an equity lens that looks both geographically at variation and disparities, but also where we have some information on race, ethnicity, demographic status. We'll try to take that into account so we can have something to say with respect to that. I want to be humble about how much we're able to do in the remaining 11 and a half months that we have, and the fact that a lot of this data comes in fairly late in the game because of lags in incurred but not reported claims for those of you in the insurance world. But we take it seriously. The Triple Aim has a sidebar, which is an important sidebar of looking at the equity across what we're doing with physical behavioral health integration, what we're doing with pop health, and what we're able to achieve with respect to bending that cost curve downward. For all three of those, we're trying to look at differential impacts across different groups. I also echo Diane's point from earlier and others that to the extent you can even broaden the diversity in many respects of your health innovation leadership network going forward to represent some of the populations that are most vulnerable, that would be great. I know you're all working on that, so I'm singing in the choir, but we're aware of that as evaluators as well. Thanks for the opportunity to attend these kinds of meetings, hear what you have to say, and offer some comments from an evaluator's perspective.
Great, thank you.
Yes, I wanted to speak a little bit to another health disparity population, and that would be people with serious mental illness and addiction disorders. And while I recognize that in terms of the commercial population, this is not as big a proportion of the population, for the Medicaid population, it's a significant population in terms of cost drivers. And a specific example in terms of well-being has to do with smoking. And we're very proud here in Washington State of how we have moved the needle on percentage of people who don't smoke or do smoke. And I can tell you that in our state and across the country, we have not moved that needle a single bit for people with addictions and serious mental illness. And that causes and contributes greatly to the shorter life expectancy. I would love to see some focused attention and a collaborative effort between plans, HCA, DOH, to actually provide the evidence-based interventions that help people with addictions and mental illness quit smoking. It can be done, it's effective, we would save money on the medical cost side, and we would save lives. And I've been beating this drum for a while, and I'm gonna keep beating it.
Do we have evidence? Do we have the evidence to show what works in that?
Yeah, I think we do. Steve Bartels at Dartmouth has done a lot of research over the years. The CDC has taken this up as a winnable battle. So yes, we have evidence. And it's basically that you do nicotine replacement therapy and support psychoeducation and support with patients. It's not hard, but it's different than a helpline. We know how to do it.
There's an interesting study out of the VA system in Southern California that I read a couple years ago that you can get, that is the VA population, but they could get tobacco use to be stopped amongst that group if they address the underlying depression. And so there's a real interesting relationship between depression and tobacco use. It's or mental health issues. So you deal with one, and you in many ways can deal with the other. But you can't deal with the depression by dealing with tobacco use. You have to deal with the depression by dealing with depression, and the tobacco use follows in that.
I love that. That resonates. So I do agree. Obviously, we need to stop smoking. However, we need to continue to look at prevention. And so if you talk about that, then talking about preventing behavioral health issues before they become behavioral health issues by focusing on family and focusing on screening for depression as young as 5 or 4 and looking at what you can do as a region to work on that. That gets it before we get down the road. So
So there's I'm trying to watch, and my job's really a facilitator here, and so I'm trying to watch for where patterns are starting to show up in the conversation. And so I'd like to maybe take a shot at articulating what maybe some of the things I've heard. So one of the first things I observed in our conversation today was the group really seemed to respond really well to the idea of success sequence marrying up with the triple aim. It seems like a really powerful way to think about that. And I don't know, did that, I know I resonated with it, but I watched other people. Does that seem to be a space where there's a lot of it resonated? Okay, so if that makes sense, then I also heard that we are pretty interested in our kids and the children and creating a healthier future for those who already are not on the path to a less healthy future. So that one seemed to come up. The making sure that we can be really effective around the fact that health equity ought to be specifically a part of how we go forward. So health equity, it plays across all things, but that can be maybe an agenda that we're thinking about. And how we define health equity. I've spent the last 18 years of my career actually working in the health equity space. I created in Maryland the first non-academic Center for Health Equity in the United States, and we became a really powerful voice in Maryland in that space. And one of the things we learned is that we had to be better inside the delivery system, but most of the health status challenges were in the social determinants of health. When we delivered babies the same, but the mothers came in differently depending on what social group they came from, and it was really, we learned a lot in that space. And I'm trying to do that here. But health equity, you have to put that lens on or you're just gonna miss it. So I heard that. I've also heard that that there's this kind of urban, rural, the challenges are differently where there's less access to infrastructure and providers and things like that. And I think you, Sue, referenced that. You called it the fringe of the frontier. That's it, the frontier. So, and so those of you who work in that space, that's you live it. I kind of work mostly in urban settings, so it's not quite surreal for me. But that seemed like an area where there was a really interesting set of conversations that we've had. I think we also had some interesting conversations around the fact that diversity and which is different than equity but the diversity issues, gender, race, ethnicity, all those kind of things ought to be a lens that we look at things like that. And I think I've also heard that getting a few things we can win on, might be a really engaging way to start trying to create some momentum. My chief operating officer is an amazing lady, and she says you can only do 3 things, Bill. Of course, I don't ever listen to her, but 3 things, because no human being can really do more than 3 things. Don't boil the ocean. And so I submit, what 3 things, what 3 areas might we think about? Or maybe it's 4 or 5, but clearly if it's 21, we're not gonna, in any given time, it's not gonna win because you can't boil the ocean. So does that capture some of the sentiment that we have here in this group? Okay. Yes.
That no longer looking through an equity lens, but actually coming up with a prescriptive method on how to integrate health equity into what we're doing. So I think for 2 years we've thought about and talked about a lens. I'm done with that though. It's been a long time. We're at the point now where we're going to come up with a plan and we're going to talk about implementing. So I'd like to get a lot more direct in that part.
Okay, great clarification on that. Does that resonate with the group? Okay. one of the things, so I've gotten to talk to Sue now three times on the phone, and now I got to meet her today. The stories of how through her career she's not had what we see as traditional constraints get in the way of getting something done, and how she focused her efforts and created momentum that created more momentum, I think will be really useful for us as we think about creating the agenda. Because you didn't boil the ocean, you didn't start with what you ended, I don't believe. But I think we have interesting opportunities in that space as well. Yes.
I hope you don't mind. I think we were talking about longer term tactics. If you don't mind, if I can share something about that. I'm very privileged to be here, and I'm always aware of the fact that many of our conversations are similar, even though we're coming from different disciplines, different backgrounds, different missions, which is about serving others. And I'm grateful for that, because I don't, in my day job, have the opportunity to sit around with thought leaders from varied disciplines about these things. So I'd like us to consider that the value of meeting and the value of having these big picture conversations is as powerful as the work that we actually endeavored to do around certain initiatives. Because I just want to share with you my concern about the battle that's coming with the changes to our tax system, and the concern that there will be less money available to serve the people that we care about. And so I'm encouraged that we're meeting, not just because we're talking about initiatives in this state, but because this state is going to have to fight in the future to preserve what we have and to encourage the innovation that I think Washington State is known for. And that's what brought me to this state, was the fact that it was a thought leader and a catalyst for the kinds of change that we believe is necessary. And I think there's a big battle coming. And I think it's a good fight and it's the right fight. But I'm encouraged to be in this room, not just because of what we do, but because we're talking about the work that's necessary over the next 10 to 20 years to preserve the best interests of kids that are being born now.
Money, and we have to get our heads around. We've got to stop wasting money because we can. So you're right on. Okay, but we can't end with that gloomy kind of note. So Laura, give us our directions.
So before we do a quick meeting evaluation and hear some final words from this group as well as from Sue and Bill, I do want to talk about how we might advance an action agenda. All of this today was being collected either in live capture, or we have a recording that we'll go back to try to figure out what might we focus on and what might those three things be. So we'll be putting that together as a staff team with Bill and Sue, and also kind of testing what the next steps might be with this group. I think kind of operationally, as we build out the action agenda and thinking about what worked well and what might not have worked well last year as far as working together on an agenda to some points that came up today. First of all, I would ask everybody, in addition to the live capture and the conversation, you do have a sheet of paper in front of you. And I recognize that the conversation hasn't been super focused, but I think that's okay, because if there was something that really resonated with you, something that is of interest or that you have accountability or influence over, either in a targeted population or in any of the levers that we can pull, I would love to know what those are. So please take a look at the leave behind in front of you and fill that out. And if we have any questions, we'll definitely circle back around. Also, we do have an April meeting in which we were planning on coming back together to talk about and to really finalize what the actions will be that we'll do individually and as a group together.
The question on the table is what kind of homework do we need to do? Who would want to be involved in shaping whatever straw person agenda, maybe in a more hands-on way? Or, you know, the option on the table is that we share in early April via email, you know, a straw person, and we get some feedback back. So we could do this a lot of different ways. So I'm interested in your thoughts on that, if there are any major thoughts or preferences. And then also, we've been capturing today who else needs to be at the table in order to make sure that we're advancing an action agenda around well-being. We have a lot of leaders from different sectors in this room, but we don't have everyone. So who else needs to be here, either as a leader, as a pioneer, as an accelerator broadly, and or who needs to be here specifically for the action agenda? So if there are any thoughts about how we come together, do homework, put the action agenda together, and who else needs to be engaged? Everyone's writing now. Yes. Yeah, definitely. Housing leader. And we don't have Bill Rump in the room today, unfortunately, but we can. Community. Community food banks, Food Lifeline.
I just want to take a moment to express a concern, and that is I want to make sure that we as a group are really aware of what accountable communities of health are working on, and that we align what we do with what accountable communities of health have been working on for a number of years already, because the last thing we want to do is have that not be aligned. I think we could build on that, and we could amplify and accelerate. I just want to make sure that we maybe build in a way to learn from the various ACHs. What is the body of work? What are their aspirations? To use that as a jump-off platform.
Great idea. Okay. We're going to take all of this feedback and start synthesizing and putting it into something that feels actionable and important. I really appreciate all of the feedback today. I'm wondering if we could do a quick plus delta of this specific meeting. We want to make sure that we keep you coming to these meetings and that these are a valuable use of your time. So as we look forward to April and beyond, what worked in this meeting that we would want to see at future meetings, and what didn't work, or what would we like to see more of?
Having spent the first 40 to 50 days with in the governmental sector, and it is great to see all the private partners around these tables.
Everyone's just neutral on today.
Inspired I've ever left this meeting personally.
Inspired. That's great.
I appreciate the invitation for the mic. This is in alignment. I was talking to Maura. We had an executive team meeting all day Monday to try and figure out, again, we're constantly looking at strategy. How do we revitalize Grace Harbor County? Not just the east side, but the west side. And as some of you know, we've got big challenges ahead. How do we meet that need? But we are so passionate about innovation. And we are so passionate about looking at it differently and committing to doing it differently. So I feel like I found a tribe here, and that's always invigorating and a lot of fun. So thank you.
Thank you.
I would just reflect that I think it's remarkable that folks who come from so many different walks of life can have the level of conversation that we do in these meetings. And gain consensus around ideas. And I think today was a great example of how the conversation got furthered given the input by such a diverse group from around the state.
Thanks, Nancy.
I'd also add, and building on Jonathan's comments, I think this is the first meeting where we talked again about the broader themes and strategies in public policy, but did not get stuck on the tyranny of what's needed for the waiver, and instead kept a very big picture focus on what we need to do in addition to and beyond an interim funding mechanism and sustainability. So kudos.
Thanks, Peter. All right, I'm going to turn, oh, go ahead.
So I just have one more, and we're looking at the change section right here. Again, like I said it a second ago, I'd like to get a lot more prescriptive in what we're doing. So I feel like we've been together for quite a while, and we've been having a lot of conversations, but the point of getting some action items down where all of us are following them, and even going to your point of us getting very innovative and even daring to fail at that point, I don't think we're there yet. So I'm glad everybody's at the table, and I think it's a good conversation that we're having, but I rarely walk out of this meeting patting myself on the back thinking that I've really accomplished something, because there aren't a lot of plans coming out of this meeting. So when I go back and I talk to our stakeholders, which is our board and our community, I'm not telling them a whole lot about what we're changing. I'm telling them a lot about a conversation that we have. So I'm happy that we have the people in the room with a conversation, but I'd really like to get to the point where we're getting tangible at this.
John, he wants us to build a public health equity PMPM into all of our rate setting.
So I'd like to reflect that one of the advantages of being able to attend is to have what the conversation was do more than seep into my consciousness. And I appreciate the comment you make about what's going to actually get done. But every day we make decisions in DSHS about how we serve our clients and our customers. We make plans about strategic initiatives. We expend resources. And to the extent that, and I'm not trying to the extent that I'm influenced and my team is influenced by what gets talked about here, it begins to truly align. I always think of a laser image, you know, incoherent light made coherent by aligning and aligning and aligning. So there may not be a specific issue or item, but this, for me, is one more piece of pushing the decisions that we make, that I make, my team makes, in that direction. I know I have a list of to-dos, actual to-dos, like talk to John and talk to Sue and talk to the State Board of Community and Technical Colleges about whether we could actually do a LARC experiment, not in high school, but with matriculated, young females that enroll and get a couple of college presidents who would be willing to take a risk and do something different. And there's a potential to do. I would say that's a small kind of project, not a big one, but this conversation influences my thinking and our thinking. It's a super advantage to me and to us.
I just want to add that I think I'd echo a lot of what people said, that it's really important that this be a diverse, representative group of leaders who also keep in mind the value of the input and innovation and creativity that frontline healthcare workers bring to the discussion, because they're the people closest to the work and actually doing it. And I'd like to see that woven in.
All right, thank you for your feedback and thanks for the active discussion today. Before I turn this over to Bill and Sue for final remarks and to close us out, I do want to remind everyone that because of your influence and guidance, we have a really robust story bank online. It's called Voices of Healthier Washington. It has videos, it has sort of blog posts from many of your efforts in the community. We put the kind of toolkit talking points around the Voices Guide on your tables. And if we run out and you need more, let us know. But we're building out the story bank this year. So please let us know if you want to brag about the work that's going on in your organization, because we would like to help make that happen. We want to make sure that we continue to highlight stories of what's working and why transformation is important. So please contact Victor or anyone at the Healthcare Authority if you'd like to contribute to that. Bill and Sue.
So I'll start off and just thank everybody for coming today and participating and welcoming me. It is really heartening to see kind of the momentum and the gravitas that the state has, and to come, meet all these legends in person. So thank you. But that would never happen without this core team of Healthy Washington folks, zealots. So Laura, Rachel, all of you guys, Kennedy, thank you for putting this together and continuing to nudge us to be at the right place, right time. So thank you for your efforts. Let's give them a round of applause. I'll just say, as I'm headed off to meet with the many members of the Labor Cabinet, because I've said it before, I feel like there's 4 cabinet members to every one in Colorado. So as I go to meet them, this has inspired me to keep thinking beyond kind of our traditional ways of thinking in healthcare. And I said it earlier, but this is not going to be sustainable, and it's not going to completely root without this ongoing public-private partnership. So on behalf of the publics, the 3 of us here, the HHS, Health and Human Service folks, we're in for this ongoing partnership, and we hope you all are too. So those would be my my closing remarks. Bill?
So I love quotes, and one of my favorite quotes is never underestimate what a small group of committed people can accomplish. And I think that's what you represent, is because there's a lot behind what you represent, because you connect in broadly into our communities. So I think it's a privilege to be working together to try to create a healthier Washington, the social transformation to health that our communities need. So thank you for your active participation, and we'll see you in April. But we need you engaged between now and April, because that we call it straw dog at Multicare, because we can't call it a straw man, so we call it a straw dog. That we're going to be presenting about the agenda. We're going to want that shaped, not just in the team here, but shaped together so that it sounds like us by the time we're done. So thank you, and Happy New Year, because I can still say Happy New Year till February 16, because that's Chinese New Year. So we're sad.